start. Thank you so much for coming and welcome. I'm Erin Brent. I'm a member of the Young Leadership Council for the Brooklyn Hospital. We are a group of young professionals working to support the hospital and create connections with our peer groups and link them to all the services that the hospital offers. We developed this town hall tonight to educate the community about the Brooklyn healthcare landscape in light of recent closures and the current climate, so that the community can better understand what the options are now and what they might be going forward. Oh, thank you. Pretty loud. And thank you to the panel, of course, for being here to help educate and talk about where we are and where we might go next. And thank you as well to Michael Cahill, Vice Dean and Professor of Law here at Brooklyn Law School. And thank you to the school, of course, for hosting. And with that, I'm going to turn it over.
Thanks very much. Welcome to you all, and thank you for coming. I'd be remiss if I didn't take this opportunity to throw in a plug for Brooklyn Law School's Center for Health Science and Public Policy. Here at the law school, we're obviously a member of the community and very interested in healthcare issues as a participant in issues surrounding our community. But we also take an academic and intellectual interest more broadly in issues relating to healthcare, both locally and nationally. I'd also be remiss if I didn't issue a few thank yous. First to Karen Porter, the director of our Health Law Center, who is here. And to Deborah Niederhofer, the Vice President and Chief Development Officer at Brooklyn Hospital Foundation, who jointly did all of the work behind the scenes to make this event happen and make this event a success. And I'd also like to thank the people in our events office, Liz Alper, who I have seen floating around, and Linda Harvey, our Dean of External Affairs, who helped set everything up tonight. So many thanks to them. Let me just briefly introduce our panelists, many of whom might already be known to you, and then kick off our conversation. So sitting immediately to my left, your right, facing me is Brooklyn Law School's own adjunct professor Sal Russo, who also has a day job as Senior Vice President and General Counsel at the New York City Health and Hospitals Corporation. To his left is Dr. Miriam Vincent from SUNY Downstate. Next to her is Dr. Richard Becker, the President and CEO of the Brooklyn Hospital Center. And to his left is Wendy Goldstein, the President and CEO of the Lutheran Healthcare System. And last but not least, we have Karen Heller, the Executive Vice President of the Greater New York Hospital Association. So a perfect panel to discuss issues surrounding healthcare and specifically hospital care here in Brooklyn. So just to start off the conversation, I'd like to try to get a sense of the lay of the land and where we currently are with respect to healthcare in Brooklyn, because it's fair to say that healthcare and hospital care in Brooklyn faces an uncertain future, but it also faces a bit of an uncertain present. So it's a little bit tricky to get a sense of exactly where things are. I wonder if maybe Dr. Becker could get us started by just sort of describing the current situation and the recent past and how we got where we are with hospital care in Brooklyn.
Thanks, Mike. We pause for a minute. I want to thank also our Young Leadership Council for sponsoring this. I also want to thank Debbie Niederhofer as well as my panelists. How we got here, we could write a book on that, I think. And it's a question that's talked about a lot, but it's not a coincidence is the first thing to say. And for those of us who work in hospitals or manage hospitals or are providers, it's been very predictable that we'd end up here. I think what underlies all of this, and it's not talked about so much, is that healthcare is changing. And for all of you who use healthcare in one form or another, much of the care that used to be received at or in or around hospitals in many places, perhaps, or definitely not in Brooklyn, but in many other places, that care is received outside of hospitals. And many things that happen inside of hospitals out of necessity, because that's the only place it could happen, now happen in sites that are not hospital-based or even in many cases related to hospitals. So for a large part of care, hospitals are just no longer involved. And along with that, reimbursement for that type of care has decreased and moved away from the hospital. So there's been also a shift in financing Some of that shift is at the national level, some of that is at the state level. And so those are some of the, larger forces at work just across the country. I think more locally, you have to look at what's happening in New York State and also in New York City with how hospitals work. Brooklyn itself it's a very fragmented healthcare delivery system. I mean, there are some exceptions, and I would say Lutheran, for example, has a very well-developed healthcare network that's been developed over many years. If you look up in the Bronx, Montefiore also has a very, very well-developed outpatient network that's really more focused on keeping people healthy than it is on hospital care and delivery of care for inpatients. We've not been so systematically focused in Brooklyn to create a system. What we have is, as a borough, a large number of healthcare sites that sometimes work together, sometimes don't, but mostly in a very uncoordinated manner. And we're really not set up to deliver care efficiently relative to the reimbursement, which kind of leads us to the hospital problem in Brooklyn. That is, it's very difficult to run a hospital profitably in Brooklyn. Right now, there are, maybe 3 hospitals that are safety net hospitals, and that they provide care to a large number of low-income patients, many of whom are on Medicaid, or many of whom are undocumented and have no insurance at all, yet we do it at a profit. And then the majority of hospitals delivering that type of care, because of the margins involved, and because of the disparities, not just in healthcare outcomes, but in healthcare reimbursements that exist in Brooklyn versus higher income areas like Manhattan, it's very difficult to create a margin, and the result of that is we don't have enough money to reinvest in creating a more coordinated and efficient system. So it's a real struggle for us as hospital CEOs, for physicians, and for really anyone who's involved in the delivery of care to build the system of tomorrow that patients everywhere are using, yet allow that transformation or that shift to happen in the short amount of time. And then lastly, and I don't want to use up all the air in the room, I feel I should give an aside. I always feel happy when I go before Wendy, because Wendy's very thorough and usually gives very complete answers. So I'm glad to be able to start. But I think Obamacare, and that's another whole discussion, but the Accountable Care Act, while its visions, I think, are good visions for what it wants to accomplish, the cuts that we, especially in New York State and in New York City, experience are really nothing short of devastating, in that New York's been very liberal in enrolling Medicaid patients over many years, and Obamacare shifts money in such a manner, and Karen is really the policy expert on this, but shifts money in such a manner that really damages New York City, and specifically Brooklyn, and private safety net hospitals get hurt tremendously. So let me stop there. I mean, that's I think a broad view of how we got here, and perhaps others have commented.
Maybe if I could follow up with a question for you, and also to bring Ms. Goldstein into the conversation. Both of you as CEOs of hospitals, it's no secret to anyone here that a lot of particular hospitals in Brooklyn have closed or faced potentially the imminent prospect of closure. A lot of the trends that you've described or problems that you've set out are not necessarily specific to those hospitals, but might be general to a lot of other providers in Brooklyn. So I'm wondering to what extent it is the case that those same dynamics or pressures confront you as hospital heads, and if so, what you're doing to try to help overcome those obstacles or confront those concerns.
Well, I think every hospital is its own story in Brooklyn, certainly, and Lutheran Healthcare is very fortunate because people 40 years ago had the foresight to say that we needed to collaborate with our community. And so instead of building hospital clinics, which is what all the other hospitals have, we became a federally qualified health center and organized our clinic system under that. What that enabled us to do is get paid for what it cost us to provide the care. That's a very unique idea in healthcare in ambulatory New York for many, many, many years. There was a cap on how much a clinic could get paid, and that was for years, $64, no matter what you did. Lutheran, because it was a federally qualified health center and based on cost, when the rest of the community was at $64, was up at $185, because in fact that's what it actually cost us to provide the care. So we had the advantage of not developing enormous deficits. But I think that gives you an idea of where hospitals are starting from, because a lot of the changes that are going on today look very reasonable if we were at a good starting point. If the hospitals in Brooklyn did not have large deficits, many of them, if they didn't have large debt that they were carrying, perhaps this idea of focusing just on ambulatory care becomes a doable thing. But the reason why you're having hospitals really close at the rate you are is that all that's changing. We shouldn't be misled, however, to think that the hospitals that are viable are strong in Brooklyn. Certainly, we are financially very fragile. You cannot work with, I'm glad Richard called it a profit. When you make 0.26% as a margin, that's more of a rounding error than a surplus. And to try to sustain growth and change and build things becomes very, very difficult. So we've been lucky. We now have 65 ambulatory sites throughout the 4 boroughs. In addition to that, we also had the luck to own a health plan. We owned our own Medicaid health plan, and we were able to sell it for a profit, a very significant profit. And that gave us what we never had before, which was an endowment, a base. And I think if you look, I'm jealous about Richard's young development people that have engaged with the foundation. I think that's fabulous. But so many of the hospitals in Brooklyn have a very difficult time really engaging significant philanthropy. And so without philanthropy, low paid, and a very high percentage of patients who are Medicaid patients, and therefore not covering their costs, and uninsured, you're in the situation that we face today.
You've described some financial concerns that face hospitals. I wonder if you could say a little more about to what extent those financial issues facing hospitals have already translated into care issues facing people who need care, or whether that's immediately on the horizon. I mean, as potential patients or people who consume health care, to what extent should we be concerned about what's happened or what's on the horizon?
I think we have to be very concerned because hospitals like Lutheran and Brooklyn are very devoted to provide care to everybody, and we do that. But if there is a closure of institutions, if there's a lack of providers, then our best interests, our best determination to provide care to everyone, regardless of their ability to pay, and Lutheran, which really is a social ministry of the Lutheran Church, is founded on that principle. But it is a very difficult situation to maintain because Obamacare is reducing the care that underwrote charity care. So even if you have the dollars, and hopefully many of you will continue to have those dollars, there have to be the institutions in existence. There have to be the providers, the doctors, and so on that exist in order for you to access them. So.
Yeah, I agree with that. I also think, there's a cultural difference in how people access care in Brooklyn, and it's widely documented and known that people rely tremendously on their community hospitals and on the emergency rooms of those hospitals. So our emergency room is no exception. In fact, it's fairly typical for Brooklyn. We have a high number of visits, but half those visits are fairly low acuity visits. Many of those visits in another community might take place in an urgent care center, or even better, at a primary care physician's office, where not just the acute episode is managed, but the health issue on a chronic basis for which many of our patients come, chronic diabetes, chronic asthma, chronic heart failure, et cetera, are managed on a more regular basis. And without that, people continue to rely on their hospitals. What we want to get to is hospitals that are really focused on providing higher acuity care and a shift towards moving that less acute care, the lower intensity care, to other sites. But that takes investment, and that takes also not just investment, but it takes a change in thinking of where people access care. And that in itself takes time. You can't just build a clinic and expect people to go. You have to teach people that you've got diabetes, this is what you need to do, you need to see your physician regularly, and so on and so forth. And then and only then will you teach people not to go to the ER at 12 midnight.
And in fact, following up on Richard's point, the Berger Commission said that 46% of the ED visits in Brooklyn were actually visits that did not result in hospitalization. So, the ED is being used as the primary care physician, and that needs to be changed.
But in order to do that, we need to provide places where people can get the care and teach them about it and be realistic about it. We looked at our diabetes, and we have all these clinics in place and couldn't figure out why were these patients coming into the emergency room, and they had Medicaid. Well, it turns out that Medicaid pays for a lot of things, but not the strips that test blood sugar levels. So here are individuals who will test blood sugar every 3 or 4 days, obviously get out of control, get into crisis, and they are not going to be accessing back the primary care clinic, but go running into the emergency room. So it's a complicated situation, not just having the primary care, but needing to have really an integrated approach to health delivery, not just medical care.
Well, and there's a convenience factor as well. In fact, while it may take longer to get what you need in an emergency room, in fact, you can get everything you need in an emergency room in one stop. You can get an x-ray, you can get a diabetes strip, you can walk out with a prescription very often, and so on and so forth. Whereas if you try and do that in Brooklyn versus Manhattan or even another borough, in Brooklyn, you're going to make 5 different stops on, over 2 weeks probably to see the right specialist and get the x-ray and to get all of that. So we just don't have that many sites throughout Brooklyn that are focused on really kind of one-stop shopping for primary care, and then just the layer of care below that. And I think we need to build that infrastructure, then we need to teach people that you need to use this infrastructure regularly, and not just the infrastructure, the physicians. It's really about that. We're fortunate to have Dr. John Ford, who we recruited, who's an expert in population health. And Dr. Ford comes from Johns Hopkins and has built his research career, and we're boasting now a little bit, but has built his research career around just this, looking at different demographics in urban areas and identifying disparities and figuring out how do we reach the pocket of asthma that's so bad in this neighborhood. How do we reach these folks who have a higher incidence than usual and a worse outcome from heart failure that are in this neighborhood? And if we can do that, then you can start to change how they think about their illnesses and how they access primary care and specialty care. And that's the focus of our research, and really it's a translational research piece, because he's doing the research and helping us move it out into the clinical environment. And that's where, along with the infrastructure, that's where healthcare needs to shift to in Brooklyn, which has happened in other places like the Bronx with Montefiore, but it's just not really happened in Brooklyn in the scale that it needs to.
We've had the opportunity, just because our emergency department is such a key part of Lutheran. Lutheran is a level 1 trauma center. There's only 3 of those in Brooklyn, and we're the second busiest in the state. So we focused a lot of our resources on our emergency room, and we actually have a section of the emergency room that is set up so that you don't even have to go back, so that we're taking care of these primary care visits, if you would, with a treat and release program right up front. So something like 25% of patients never even go back into the back at all. But again, it's a matter of how do you connect those visits with the ambulatory care network that we have in place. And we've done that with information systems. But we need money to do that better. We all know that the best way to build a network is starting with the data. But that takes dollars. And without dollars, it's very difficult to do.
It sounds like all the speakers are suggesting that the role of hospitals in providing care is going to change over time, and possibly that it should change. Maybe, Ms. Heller, if you want to comment on this, where do you think we're going to be less hospital-centered in the future, and should we be less hospital-centered in the future than we've been in the past? And how, if there is going to be a transition, how are we going to negotiate that transition, either financially or in terms of the way we provide care?
Thank you. It's a very interesting question. And because the identity of the hospital is multifaceted, right? So the core thing that a hospital does, that it's always done and has to continue to do, is provide inpatient care when people are having an acute episode, emergency care, and trauma care, which is part of emergency, but as Wendy said, not everybody does that. Those are core things that hospitals have to do, and there are a lot of programs in place and emerging today to drive reimbursement policy more on quality and efficiency than simply on traditional fee-for-service. But that is a very, very core thing. The other major trend, though, and this relates to community hospitals in terms of the regular care that they provide and the linkages with communities, the other thing that hospitals need to do is lead or participate in organizations with ambulatory providers and other community-based organizations, social services, all the rest of it, to essentially follow the patient from where they are in the inpatient setting to all of their different stops along the way to getting home, and then if home is in a residential facility, then working there. So the concept is called patient-centered care. And what it really refers to is you don't work on your piece and then say goodbye and not care what happens next. That you have linkages with every step of the way and with the patient and the patient's family. And a lot of hospitals want to form larger organizations that can lead a community in that effort, but the regular traditional hospital stuff will still be there. Okay, it's just, so when we talk about hospital, I prefer to use the term medical center, because today, like Wendy and Richard's places, and SUNY as well, they really are medical centers. As you've heard, they've emphasized enormously the outpatient function. And so much of care that hospitals used to provide is on an ambulatory basis. So, you know, the inpatient part is the fundamental sort of core traditional business, and that will always be needed. But this other part is something that they have to participate in even if they don't lead. And one of the other points that I just want to reinforce that Richard made is, in the past, before technology and science permitted doing a lot of procedures and taking care of people more on the outpatient side, the care was focused on inpatient, all right? And a lot of money was centered on the inpatient stay, okay? And as Wendy and I were discussing early this evening, that was done by design, because so much of the hospital's business, it really started as an inpatient business. And as you know, both of them have said tonight, the outpatient component has been grotesquely underfunded. And so now that there's less that needs to be done on the inpatient side, the need for beds has declined, and along with that, any sort of surplus that there was. And I just, in case there's students in the audience or people that are not, really familiar with hospital finance, when we talk about profit, what we mean is if you think about your own family, right? If you are just making enough money to pay your day-to-day bills and not saving any, you can't get your car repaired, you can't get your house repaired, okay? That stuff is called capital, all right? When you have to make a one-time payment for things that just come up. Hospitals, the rule of thumb set up by actually the Federal Housing Administration is you have to save 3% of what you get. So you get paid money, and 3% of that money you should be putting away every year so that you can keep your facilities up to date, so that you can keep your equipment up to date, so that you can install new safety code standards as they come up, so you can meet new requirements, so you can invest in information technology. This is critical. So when Richard and Wendy talk about profit, what they're simply talking about is the need to save, because these are not-for-profit institutions, right? The need to save so that you can invest in the things you need to invest in. And the problem is, for the Brooklyn hospitals, for a lot of reasons we can go into if we care, the margin has, the ability to save has really been stripped out. And it's not their fault, and it's really a tragedy. And this is what the Greater New York Hospital Association is particularly concerned about, access to capital and the ability to even service the debt. I mean, one of the reasons Interfaith got into trouble was a very, very high debt load, a relatively new facility. St. Vincent's the same thing. So, what we need in Brooklyn, which has the fastest growing population of any county in the city, and even in the surrounding suburbs, thank God. I mean, we're really having a big renaissance here, is support for facilities to make the changes that the current system demands.
As a family physician who's practicing primary care, chair of family medicine, and a lawyer also, I can tell you, I still make home visits, I still see patients, and in my lifetime, not only has healthcare finance changed and the type of care we deliver at hospitals, but our entire need for medical care has shifted. We no longer really care so much for acute infectious disease. There are no TB hospitals around anymore, right? We used to have TB hospital at Kings County when I changed. But rather, we're dealing with the acute manifestations of chronic illnesses, diabetes, hypertension, hypercholesterolemia, that disproportionately affect our Brooklyn population. So I'm happy, unlike everybody else sitting up here, that now folks are beginning to want to pay primary care physicians. Because that's where all folks need care. I have school-based health offices. Nobody mentioned that. We take care of 22,800 kids in Brooklyn. I'm in the schools. I have two kinds of centers alone in family medicine, one in the hospital and one out in the community. We have the same doctors at both centers, and yet there is a culture that wants to come for the one-stop shopping. And I think our medical centers in Brooklyn do need to pave the way, and we need to show how we can develop not only IT, but healthcare delivery systems that provide that one-stop shopping in the community, which we've done in our community health center, although it's been a struggle. We're now approaching equality between my Suite B and University Hospital of Brooklyn and our family health services out in the community on Lefferts Avenue. I think as we look at healthcare, the finance is changing, and that's good. There will still be a core need, I agree with you, but for much less acute care. If we really do our jobs right, we'll keep people out of the hospital, and that's an inefficient and expensive way to care for much of the disease that we now care for. We need, in Brooklyn, to face the fact that we need to encourage healthy lifestyle, preventive care, and have that one-stop shopping that our patients are looking for in the community, we can set up these models because the type of care that our community needs is so different. A lot more education. For example, as we develop, and I sat on Governor's Council for 10 years, I helped draft the first RFA for medical home. I could never believe how important a huddle would be. At the beginning of our clinic sessions, clerks and nurses and lab techs and the physicians and residents all get together and we go over the patient list as a group and decide how will we approach this patient and work together to take care of the patient. Something as simple as that gives us such a greater degree of efficiency in how we work together to keep the patient at the center of care. Little did we realize that we could take folks from the community and train them as patient navigators so they would follow, and we're doing this. See, we're setting the model. That's our job as the medical center, to show folks how to make this work, and right along the way, we're figuring out how to make it work ourselves. And to follow these patients, our community, from the hospital to our health centers, and to help keep them well. To make home visits. Home visit is not a dirty word, because you know what? Our patients need this. To be in the schools, because there our children have access. To work with Governor's Council to make sure children have fresh vegetables and fruits, because this is how they're going to be healthy. To look at problems like obesity in the young, and how patients can work together with each other. I have one of our medical students on Thursday evenings going and doing Zumba dancing and giving nutritional advice. So we kind of have our own little youth council built in at the medical center. We're fortunate for that. So I think that we as medical centers need to think and act differently. I chair family medicine, but I'm medical director of ambulatory care. That's where the money is. That's where the focus has to be. How can I get my information systems at downstate to not only talk to each other, but to talk to Dr. Becker's and Ms. Goldstein's, so that we can share information on patients and we can more efficiently care for patients and not duplicate services. I think Brooklyn has a great challenge in looking at how we will help people to stay healthy and how we can deliver the kind of health care that our community needs. And we're on a learning curve just like everybody else.
Sal, I see you nodding your head a little bit. What do you think hospitals need to be doing both to improve their financial stability and also to be providing better care as we move forward?
Well, I think the hospitals have to realign with this new environment. They have to, the primary policy of the federal government is that, we have better care for individuals, better care for populations, and better, lower costs. And the hospitals have to align themselves in that way to provide, as was said by the panelists, for ambulatory care. Because there is in Brooklyn, in one of the reports, it was revealed that Brooklyn is underserved in terms of primary care providers by anywhere between 250 to 450 primary care FTEs, physicians. Also, at the same time, the hospitals are overbedded by a significant amount. In fact, the hospitals, as an average, are in any day are occupied at the 70% level in terms of occupancy. So that's the average, and that was in the Berger report. In any event, the bottom line is they have to realign themselves to the incentives of providing preventive ambulatory care, as the doctors said here.
Can I say 12 things calmly?
Right.
First of all, I would have to disagree that we're overbedded at this point in Brooklyn with all the hospital beds that have closed, or that there are that many empty beds. I think there's a fallacy when you look at the number of official certified beds and those that are open. But there's another problem, and we've been doing primary care a long time. We've been doing it 40 years. We're in 22 schools, we're in 14 homeless centers, and we have 9 comprehensive centers right in Sunset Park. All that we're saying is very, very important, and preventive care is absolutely right. But the payback on preventive care is long-term. So we can make a healthier population ultimately for 10 to 20 years if we're educating and getting people eating right and exercising and all that. But right now, 62% of the elementary school children in Sunset Park are obese. Right now. They need to be taken care of right now. And the dollars still are needed in the hospitals to do that, not instead of the ambulatory. No one could say anyone believes in ambulatory care more than Lutheran Healthcare. And we also have a home care program and a physician on-call program and a nursing home and a rehab center. So I agree 100% that there's more than just a hospital. But there is a fallacy, and that is if you teach people to eat vegetables, you don't need to pay for nurse staffing levels in the ICU, and it just is not true.
Well, and that's very well said. You know, what we're in the middle of is a transformation. And the other fallacy is that this transformation can occur, you know, with the flick of a switch or in a moment, and it's not going to happen. The financing of this transformation is set up to happen that way. But Brooklyn started way to the left of where it needs to be. As an example, and I think every hospital in Brooklyn faces this, and Greater New York, Karen, does these calculations and retools these calculations, but just to give you a sense of what we face, and I think, you know, Lutheran has its number, every safety net hospital has its number of how much less reimbursement the Accountable Care Act takes away over the next 10 years. For us, I think it started at 110 million, and then it went to 60, and then it went up to 70. It's a dynamic number, but it's not $2 million. It's not $3 million. These are big numbers for delivering the same care to increasingly complicated patients and trying to reinvest on the inpatient side to stay current, and also trying to build, as Dr. Vincent says, doing all the things that she's doing, that we're doing, that Lutheran is doing, and others are doing. There's not a mystery about what to do. I think sometimes, you know, there's a sense of, well, if we really knew what to do, well, we're so focused on running a hospital that we don't really understand what to do in the outpatient setting. And that's not really true. We know exactly what to do. We just don't have the funding to do it. So it's not rocket science. We really aren't we're not trying to do groundbreaking bench research or molecular research at my hospital or at Wendy's hospital. We have research going on, and we're very skilled at what we do, and we have tremendously talented physicians and nurses and staff. But we don't have the resources to transform the system in the time period that it needs to transform to stay solvent and sustainable given the changes that are occurring.
I agree 100%. You need the bridge in terms of funding to get to the nirvana that you want to get to in terms of preventive care, ambulatory care, and that's very critical. And I also would underscore that, in fact, in Brooklyn, you know, with the accountable care implementation in 2014, a lot of the care that is, you know, supplemented by disproportionate share funding and other things go away with the theory that the exchanges is going to cover this. And in New York, where you have a substantial population that needs care, that's undocumented, these individuals cannot participate in the exchanges. Moreover, the funding for disproportionate share is shrinking over time, and it's creating a problem for the safety net hospitals that provide that important care.
I have to agree with you 100%. I wouldn't say a problem, I would say a crisis. 75% of the dollars that are in disproportionate share was a bucket of money that was put aside for those hospitals that did a disproportionate amount of taking care of poor people, either through Medicaid, because it didn't cover the costs, or because they were uninsured. Because it's not just how many poor people you take care of, it's also how much of what you're doing is absorbed by these people. And so for places like Richards and mine and downstate, absolutely. We have lived, Lutheran has been getting $50 million a year in disproportionate share to pay for the undocumented, to pay for the underinsured. And now with a flip of the switch. That's going to be reduced. Ultimately, 75% of that is going to be redistributed because everyone is going to have health care and coverage. And it doesn't work that way quickly enough or at all.
And I'd like to add...
Except everyone won't have coverage.
Right.
Well, and then I want to add that, that the cuts in, what we call DSH payments, disproportionate share hospital payments, are in statute, and what's left gets distributed in proportion to where the need is nationwide. And so the states that are choosing not to participate and not to expand Medicaid, their hospitals are going to have a residual proportion of need that is much higher than was expected, and so New York will be disadvantaged in that regard because more of the funding will go to these other states. And the other point I'd like to make, just because I want to get it out there, is in the Affordable Care Act, so we have the cuts in disproportionate share funding. We have funding for restructuring the system. Another aspect, which is something that New York State also participates in through the Medicaid program, is performance-based payment. I mentioned this tangentially before. And what performance-based payment means is that the federal government or the state, they withhold a portion of the money that they pay for services, and then they redistribute that amount withheld among hospitals based on their ranking on various performance measures. And to our mind, one of the most critical flaws in the current design of the system is that it discriminates against hospitals that provide a lot of care to poor, uninsured, disadvantaged, immigrant, multicultural communities. And this to me is one of the pivotal issues of our time. So hospitals in Brooklyn that really do a lot of work in this area are going to be disproportionately hit in a variety of policies. And, I just want to mention, just to give a little bit of flavor of this, one of the things that is very important is in the hospital patient satisfaction scores. And if you have loved ones or have been yourself in a hospital, you may have gotten one of these surveys. And the survey asks, how much of did someone always come as soon as you rang the bell? Was the room always clean? Was the room always quiet? Did you, get whatever? And the problem, or what was your overall impression? Was it the best it could possibly be? And these are important questions. But if you've been starved of capital, and you can't have single rooms for everybody, and you can't have it quiet at night because of overcrowding, and because you haven't been able to restructure and invest in the kinds of infrastructure to make everything lovely, beautiful, and pristine, you are going to be punished for that. And, an analogy is to what happens in schools. And I remember this year there was the Chicago schools, there were strikes over the fact that that teachers were being punished simply because their students didn't perform as well. The technical term for this is risk adjustment. In other words, if there are things beyond the control of management, that needs to be taken into account. The socioeconomic challenges of poor, uninsured immigrant populations have got to be considered. And so a lot of what's happening above us at the policy level, so we've got our problems with the financing and everything, but there's also policies that are so much in their infancy that they have got to be corrected. The first time the federal government ever published mortality rates, there was just a raw mortality rate without any consideration of how sick people were, how old people were, what they were in for, and everybody roundly rejected that, and they came out and did something better. In all of this performance measurement, we are at that early stage when the results are really unfair, unsophisticated, and inappropriate, and not giving due consideration to communities. So that's another thing that we're really working on.
I think the best example of that is if we look at diabetes. The kind of diabetes we have, my PhD is in islet cell biology. The kind of diabetes we have in Brooklyn is the Flatbush Avenue diabetic. They're not only relatively insulinopenic, so their islet cells aren't making the insulin they need, they're also very insulin resistant. We have a vicious form of type 2 diabetes. That's not if our patients' hemoglobin A1Cs are higher, then that's going to be looked at as a failure of our ability to work with patients to get the results that the feds want. That isn't fair, and you're right.
Yeah.
So one of the things we're held to is within a community that lacks the resources and has higher rates of diabetes certainly than the rest of the country, but within Brooklyn, even more so than New York City, and most people don't realize that. There's a reason why it's called Flatbush Avenue diabetes. The last time I looked, Flatbush Avenue was in Brooklyn. And, these are the kinds of things that are going to have a negative bottom line for us, in addition to which, for our private payers, while the dish is evaporating, for the same diseases, inpatient largely, we're seeing 35 to 40% less in reimbursement for Brooklyn compared to Manhattan. And I'm wondering how that's hitting hospitals. I know its effect on downstate, but...
Well, I think for us, it's very devastating. We know that small hospitals, which relatively speaking, there were 450 beds, relatively speaking, I used to run Mount Sinai Hospital, which was 1,212 beds at the time, and I think it's even much bigger now. So we're a relatively small hospital, and our ability to negotiate rates and our ability to get good prices for things is at a real disadvantage. So when you look at what hospitals in Brooklyn get paid overall, it's significantly less for the same exact thing. This is what's important. There's sort of this aura about going to a major academic medical center and suddenly something's different. It isn't different. Cardiac catheterization with an implantation of a stent is the same in my hospital as it is at my partner Mount Sinai's. When Mount Sinai takes the patient to Brooklyn, takes the patient to Manhattan, they get 4 times what I get. So, I think that one of the problems is that there's a lot of soundbite medicine going on. There are a lot of things that sound so real. Why shouldn't hospitals that don't give good quality get paid less? Why shouldn't hospitals that patients are unsatisfied get paid less? There's all kinds of doctoral dissertations now that the Chinese community, in fact, rate approvals lower than any other community. And the data is there. And it doesn't matter. It's ignored. And we're doing this against the background where Utah, the profit margin average in Utah is 12%.
And isn't there a question of, are these surveys that are conducted in different languages? I mean, are they in different languages?
They are.
They are, okay, so there's no...
But they don't take into account, as Wendy pointed out, the cultural differences in satisfaction. And the questions, as Karen said, are, they're very standard questions. And, not everybody thinks the same way, and everybody has different expectations or standards. Certain groups of patients wait until, they're in severe pain, until their disease states are extremely advanced to go to a hospital, because for them, a hospital is just a bad place to be, no matter what. Other groups are the opposite. My father's one. If he has a tingle that lasts for a second in his little finger, he's in the emergency room.
And you're with him, right?
And I'm with him, but he can pass out and not tell me for 2 weeks. So that's a different story.
A few of you have...
There's a wide variation in this, and so that's not reflected in the patient satisfaction surveys upon which some of our reimbursement is now based. So.
A few of you have alluded to the Affordable Care Act, also known as Obamacare, and Ms. Heller described some of its performance-based pay mechanisms. I wonder if you could respond more generally to how you think the Affordable Care Act is going to change or contribute to the changes in Brooklyn either positively or negatively? Is it going to have a big impact? And if so, what will its impact be?
Okay. It's not going to have as much of an effect in New York State as it would in other states, and others have mentioned this already. New York has a really robust social safety net, the whole state. In particular, when we talk about long-term care. And even though we're all really concerned about psychiatric care and what the demise of interfaith means for that, still the state has had a much more robust investment than other states. So for example, when we talk about coverage expansion, one of the things that I don't think a lot of people understand is that most of the people who are uninsured in New York are already eligible for Medicaid but not enrolled. But when people need hospital care, they are enrolled because the hospitals will help the patient find out if they're already eligible. So in terms of new people coming onto Medicaid, by and large, they're healthy people, and so, I don't think that will overburden the hospitals. Likewise, people have been using the emergency room, and we also have, in New York, and I'm very proud of it, a very robust financial assistance law. And hospitals must provide care to, well, any hospital in New York City has to provide discounted care to everyone who lives in New York City. And so people are able to get care also because of the EMTALA law that says you come into the emergency room, that's national, of course, and you're taken care of. So I'm not expecting a lot of incremental revenue. Having said that, there has been a tremendous crisis, and the intent of the law is very, very important, which is to make a market for individual insurance. It just has not existed, and there was an article today in the Times, I think it was, about how the reason that the Affordable Care Act is working out well in New York State is because we have always had a requirement that that for individual policies, insurers could not discriminate against people with pre-existing conditions. On the other hand, because people were not required to get health insurance, it was completely unaffordable. So introducing the Affordable Care Act here in our state is actually making insurance more affordable for people who don't have employer coverage and who have been priced out of the individual market. And this trend is critically important. The percent of the U.S. population with employers coverage was 69, almost 70% 10 years ago, and it's fallen 10 percentage points. I mean, this is a crisis, and so I've always supported the intent of this. I'm concerned about our facilities in Brooklyn and in other poor areas where I don't expect that a lot of new revenue is going to come in to offset the cuts. And, it's pretty unfortunate that we didn't get, that the country couldn't get bipartisan support for this, because changes could really help it a lot. And opponents of the bill prefer to not change anything so that when there's a flaw in it, people suffer and hope for its demise. But if states are not going to take advantage of the coverage expansion for Medicaid, that means that the money that was set aside for that is not going to be spent, and they don't have to cut disproportionate share funding and a lot of the other cuts that were made in anticipation of spending all this money. So, it would be, our hope would be over the next few years that Congress could work together and find ways to to moderate parts of the bill, just as had been done since the inception of Medicare and Medicaid, over 40 years ago.
I think the other point is, access to care is dependent on the existence of people to provide that care. And as we know from downstate, there is not an increase in the graduate medical education availability in this country, nor the payment for it. So I may feel that I could train many more people, or Richard, and we're not allowed to. And so even though we have a large family practice program, which is primary care. We have a large internal medicine, a pediatrics, all these primary care places to train people. They are being capped because it's a different piece of legislation. And this is what's happened. There is a bunch of different legislation, and nobody is standing back and sort of looking at it and making rational decisions. So it's fine to give people more insurance, but they've got to have a place and a person who's going to provide that health care. And we have not compensated for that. And in fact, they're talking about cutting graduate medical education reimbursement, something which hospitals like ours depended on for a long time. And part of that is because New York has gotten so much of it, and it seems unfair. But one out of every 7 physicians in the United States got trained in New York State. So yeah, we do get more graduate medical education money, and we should.
And just to add to the comments, I think the Accountable Care Act has a good vision, and it wants to accomplish, much of what Sal mentioned around the triple aim, and those are good objectives. So nationally, the goals are great, but there really wasn't consideration to what the impact was, certainly in New York State, but when you drill down to Brooklyn and its unique issues, there are over 2.7 million documented people and another 300,000 or 400,000 undocumented people. There are 1 million people or more on Medicaid now, which is an incredible number. And every Medicaid patient isn't the same. As Dr. Vincent mentioned, the illnesses our Medicaid population has and the social issues that many of our patients have are just much more complex and much more challenging to manage. And that takes time, money, and resources to do, all of which is eroded. The other piece that Karen was talking about, which is this decrease in employer subsidized insurance, it really represents, and I like the idea of an insurance market, but I think the insurance market, the threat is the quality of insurance that's available is being eroded. And for hospitals and for all providers, that ultimately means potentially less reimbursement for delivering care to more complex patients that demand more time, resources, and so on. So that in itself is a challenge. You can have an insured patient, but not from a provider perspective, not every insured patient is the same financially. And we deliver, and we're very proud of the fact that at Downstate, at Lutheran, at Brooklyn Hospital Center, and really at every hospital, we don't differentiate the care we deliver based upon your ability to pay. That's very different than other service industries. Very, very different.
And other institutions
And
outside of
other institutions. So that's right, and forget other industries. In other areas, there is, what we call a wallet biopsy, and, you can either get in the door or not. But everyone is welcome to see our physicians and to stay in our hospital, and likewise to my colleagues. And that has a cost. And that function is really in jeopardy under the erosion, I think, of insurance.
Yeah, maintaining one level of care is a real challenge, especially in Brooklyn. Our patient care mix at our community health center is fabulous. We actually make money in family medicine. Think about that. However,
Would you like a job?
No, I already have 3, thank you. However, it's a real challenge, and you've got to be open at night, you've got to be open on the weekends, you got to be there when people need you, and you have to have a range of services, primary care, podiatry, nurse midwife. This is what folks want, this kind of care we need to deliver. But at the same time, when we look at our patients that get admitted to the hospital, they're 5 times more likely to have Medicaid. So you look at who we're caring for in the outpatient setting, then you look at who's coming in. It's a very expensive population to care for. That's one problem. The reimbursement is less, that's another problem. So now I'll turn to my colleagues and why don't you talk about how much that bed costs. Because let me tell you something, one of the things I learned in law school, right, you have to look at both sides of this equation, is that everywhere else when technology comes in, the cost drops. Look at the first VCRs, they were $1,100. When was the last time you paid $1,100 for either a DVD player or a not, right? But look at medicine. Look at the new genetic treatments and technology. When something comes in and it's technological, they're going to hit your wallet and hit your bottom line.
Okay, I really want to respond to that.
Yeah, great.
Okay,
I'd
so the cost of gallbladder removal has fallen considerably. Okay? The cost of the things we used to do has come down. The issue is that we are able to do things that we couldn't do before. And the more things exit the hospital, the more expensive, on average, the care is in the hospital, right? It's a higher proportion of intensive care, of quaternary care. I mean, you listen to the discussion now of our war vets and how such a higher proportion of people are surviving now than ever have before because of technology, but the cost of that is, so it's not exactly, we're not doing the exact same thing that we used to do and it's getting more expensive. We're doing really more advanced stuff. And that's, one of the things we don't talk about as a country is end of life. And the fact that, we're kind of keeping everybody alive until they get dementia. And then what?
And then we keep them alive anyway.
Right, but so there's a lot of aspects of the change in the healthcare system, and some of it has been really good, but a lot of it needs updating from a social perspective.
I'd like to leave plenty of time for questions for the audience, but as moderator, I'm going to seize my privilege to ask one final question just for everyone, very generally. My own role in the healthcare system in Brooklyn is as a patient, or occasionally, more often, the father of a patient. And as a local resident, I'm wondering if you could just share your thoughts for me. What should my expectations be about healthcare in Brooklyn as I try to raise a family here over the next decade? Should I be hopeful? Should I be concerned? And if so, what should my main hopes or expectations or concerns be about where healthcare is going and how I'm going to experience it?
You better hope you have access to high quality. I mean, that's what we're looking for. We're looking to maintain that seamless health care that really has that aspect where the patient is the center and yet struggling with all these financial issues. And I think we've heard about a lot of the problems and we better come up with some solutions. Because we've heard a lot about primary care. I'm also worried about specialty care. Where are my patients going to be able to find the pulmonologists, the other care that they need? Cardiologists still seem to be available and the procedures are in the hospital. Should they be there? Should more surgery be occurring in ambulatory care centers? And if so, how will those survive also? I mean, there's lots of questions here.
I think go ahead, Richard.
I was just going to say, I don't know how to respond to that. So I'm going to keep going. But I'm an optimist. I really am. And I think, if you're a resident of Brooklyn, I think you have every reason to be hopeful. But I think that it's hard to be hopeful with all the stuff, and let's just call it stuff, that's happening. There's a lot of irrationality that's happening now in the healthcare market. Institutions are failing, and there are real questions. Should they be allowed to fail? Well, what if they fail before the transformation and the infrastructure is built? And where should all these new healthcare sites be? And if I want to be able to get healthcare in my neighborhood nearby, understanding that as a father or, a spouse or a partner or whatever, I want to be able to get most of my health care, unless it's complicated brain surgery or I need an organ transplantation. I want to stay in Brooklyn and get my health care here, because we're big believers that if you build quality health care, people will stay local. We've done it. We were doing, a very small number of joint replacements at our hospital 2 years ago. Why? Because we really didn't have a solid orthopedic surgery department. So we said, we're going to recruit orthopedic surgeons, and we did. Now we have 4 orthopedic surgeons who are fellowship trained in joint surgery, and we've grown our joint surgery program by a factor of like 7. Okay, so we're doing over 300 joint replacements, and in 2 years, we'll be doing 500 joint replacements, which is a respectable, very respectable number for any program. And where are those patients coming from? They're not coming yet from Manhattan, but that's our target, but they are coming from Brooklyn. And there are still patients, our referring physicians will tell us, there are a couple of patients, 10 or 20% of my patients insist on going to this hospital or that hospital in Manhattan, but most of my patients are happy with the care they're getting. And by the way, our length of stay is at or below the same length of stay for joint replacement of any hospital in Manhattan. And, all the same quality metrics. And the same, you can find the same care at many hospitals. The point is that, I think this will happen. There's a lot of life support, for lack of a better word, that's going on for hospitals. That money would be better utilized in a lot of other ways. And I understand exquisitely the economic meaning of each of these hospitals in Brooklyn, of every hospital in Brooklyn, to its community and to really the dedicated and committed people who've been working there for many years. But, it is only possible to maintain that for so much longer, and that time is becoming increasingly short. I think what we really need to do is focus on how do we transform the system, how can dollars be invested, and how can those people be retrained to participate in this system that we need now and for the future, not how can we maintain the system of the past. And I think that's why I think that will happen, and that's why I'm an optimist. So.
It's happening now. We're retraining our nurses to go back into acute care, and we have patient navigators, medical office assistants, even in the medical center. So we are retraining, retooling, getting our information technology up, and you've got to move fast. And I am also very optimistic.
Well, I think the key thing is you. I think that you have got to stay engaged in this dialogue and demand that there be a thoughtful process that takes place. Because there's no reason why you shouldn't expect top quality care in Brooklyn with relationships around us. I consider it an ecosystem. There are really important things that other hospitals do, and we should never diminish those, and there are things that I do that are very important. But unfortunately, this is not an issue that has gotten a lot of intelligent discussion. And if we want good solutions in Brooklyn, we need evenings like tonight, and you have to take this on to make a difference, because we've been talking about this for 4 years. And the key is we're at the moment now where the differences need to be made, where the hospitals need to be closed, where the dollars need to be reassigned, where the things need to be invested and done responsibly. So if you care about your future and your children and your grandchildren, as I do, in Brooklyn, you make sure that you stay engaged, because you are the most important defense that we have.
Yeah, and I'd just like to make a final comment too. I love what you just said, and I love that this is occurring tonight. So the hospitals are doing really, and all the programs that surround them, again, they're medical centers, not just inpatient facilities, are doing the work on the ground for the transformation. The community is very engaged and must stay engaged. And at the policy level, we're doing everything in our power to make policy that supports communities. In particular, we're very, very hopeful about getting an infusion of funding from the federal government, okay, which is simply a reinvestment of savings that we have generated for the federal government, okay? By doing a lot of transformation already. We have saved the federal government like $40 billion over a 5-year period, and we need some of that to be reinvested, and we're hoping to target that a lot for transformation. I also agree with my colleagues that it's important to shore up those who are here and are viable and are able to make the transformation. It's critically important that all of the institutions, HHC, SUNY, Brooklyn Hospital, Lutheran, Maimonides, Methodist, all of them, have the support to really sustain what they're doing and transform. And you asked the question about quality earlier. When you have an institution that's not making it for reasons that are dictated by the circumstances of the changing healthcare landscape, we need to be focused on the future.
I just want to say, I agree, and I'm also optimistic of the future. We know where we have to be. It's the bridge to get there that has to be constructed, and one of the ways, as my colleague has said, is the 115 waiver, which will be a demonstration project, God willing, which will be able to infuse money into the system so that we can make that leap and realign the finances with the needs of the community.
Please join me in thanking our panelists, and I'm sure they'll be around for a few minutes if you have additional questions, but thanks to you all for coming.